Very good evening for today, my beloved colleagues. Very, very welcome to today's session on the topic osteoporosis management. Hopefully, all of you are fine with good health. So it's myself with my humble introduction as before, and our institute welcoming you to today's session as well. And with the moral alert, we will be going to the today's topic now. And this is osteoporosis management. So very grateful those who attended already in time, and we are now in the exact time to start the session. Hopefully few colleagues may be preparing for the OSCE as well, not only the AKT. And this topic a little different one, and it needs special attention. Previously it was thought as the topic of a specialist, but days are going on and the concepts are being more clear and easier. Treatments are available, investigations are available. So now it should be within the grip of general physicians or the family physician as well. And I can remember some of you requested us to organize the class on the osteoporosis management. So this is our pleasure that you have requested me, and gratitude to you all as well. So as our nature of the class is interactive class, so always we try to discuss the topics and asking you something you can ask, you can share. And may I request all of you today, those who want to be active much, if you have time, can you raise your hand in the system, please? Just hand raise in the system. Keep your hand raising in the session, please. I hope all of you know about it, the technical issues. Dr. Azra, can you not
Yes, sir. Yes, sir. I'm here.
raise the hand?
Sir, I don't know how to do this.
Oh, sorry, maybe technically a little different, but not difficult. So requesting all of you, if possible, you just keep your raised hand. Anyway, Dr. Azra be connected with me. And other also, you can open the mic and let me know that how much you know about the osteoporosis, what the informations you have gathered. Dr. Azra, can you start, please? Just to tell me that what is osteoporosis and how much you know, very shortly. Dr. Azra? Hello, Dr. Azra.
Yes, sir. You have.
Is a problem to unmute yourself?
Yes, sir. Now can you
Yeah,
hear me
sorry.
now?
Maybe, yeah, this is the reason, because to control the noise. And if anyone, you can raise your hand better. Anyway, what about the osteoporosis you know about? Just tell a few words.
Sir, it's a condition in which the bone mineral density is decreased and the
Right.
bone is fragile.
Very right. Then any more thing? Nothing
Um, uh,
more. Nothing more.
uh, no, sir. I know, but
The
there are a
technique.
lot of things.
Let me say something about the technique of discussion of a disease. Suppose if
Okay.
I ask you anyone that please tell me something about the disease. So you can tell many things like a PhD holder, doctorate on osteoporosis. But we don't want it today. We are physicians, we are clinicians. Our job, our idea is to tell about how a patient present with the disease and how we evaluate the patient. Okay, evaluate means investigations and others, and then how we will treat the patient. These are the basic three things, basic headlines. So from there, actually, you can discuss about. Yes, Dr. Javed. Interestingly, I am looking at the chat box, but usually I don't do the BMD less than BMD, Dr. Javed, it is not BMD. There is a value. BMD is the method, and the value is T score.
T score, yes, sir.
T score. Okay. So hopefully you can open the mic now. Dr. Javed, do you like to add?
Okay,
This is
just
T
quickly,
score less than
yes, T score,
2.5.
yes, T score less than minus 2.5.
So we label it osteoporosis, right? But there you will have some interesting data or information today also that even the T score is not minus 2.5 or less, even then we have to start the treatment. This is very interesting. Okay, any other thing anyone to add? Anyone like to add? Dr. Nawaz,
Yes, sir.
what do you like to add? New thing.
Sir, for to define the osteoporosis.
Already we have heard something from Dr. Azra, Dr. Javed. You like to add anything new?
No, sir, it's sufficient.
Sufficient. Sufficient to be a doctor. Sufficient means you
So
have no further information to add. Okay, doctor. Yes.
we do DEXA scan, sir,
Yes.
for
Name of the test is the DEXA scan, right? Any other thing?
Yes, sir.
Dr.
Assalamu alaikum.
Huma. Oh, sir, Dr. Huma, please to add something.
May I add something, sir?
Oh no, you will ask something. No, you can ask many things later on. But initially, we like
No,
to hear
no.
from you how much you know about the osteoporosis.
Yes, I just want to add you can say it's also loss of bone mass, loss of the bony matrix. So it's not
Yes.
just bone dense mineralization. That's how you distinguish it from osteomalacia.
That's right. This overall density is lost in the osteoporosis.
There is
Overall,
increased osteoclastic activity as compared to
it is a
osteoclast.
mechanism one of that, right? Okay. Any other thing? Nobody telling about the treatment.
Treatment, sir, biphosphonate.
Okay. Other thing.
Yeah,
Medication.
orally alendronate if someone is not tolerating.
These
So
all are bisphosphonate or biphosphonate, whatever you say.
yes.
Zolentronic acid, if
Other than
zolentron,
bisphosphonate.
there are injectable
Doxy.
zolentronic acid.
No, these also bisphosphonate, doctor.
Okay.
Zolendronate, alendronate. Other than bisphosphonate, what else?
If
Uh,
menopause,
Raloxifene.
if it's a
Uh,
menopause, then you can start some selective
Estrogen.
estrogen
And
modulators.
ferritin.
Yes, even then calcium, vitamin D also added as supplemental material. But the D treatment, other than bisphosphonate always the first line treatment. What could be the second line?
If contraindicated, then I think biological agents,
Monoclonal.
denosumab can be given.
Denosumab, very right. Denosumab. Teriparatide. So for
Parathyroid hormone, yes.
for GP understanding, actually we will not go beyond bisphosphonate too much because this is the first line and first line is for reserve. Reserve means GP can prescribe easily. If we need to switch to other part of the medication, rather at that time we need suggestion or referral. Okay, thank you.
HRT can we give?
Sorry.
HRT.
HRT is different thing, doctor. Yes, we can for the postmenopausal lady,
Yes, we
especially
can.
having the premature menopause. They need
Mm.
bisphosphonate. They need bisphosphonate. So with this introduction, we
So,
will be repeating or explaining. Let's go with
so
us. Anything new to add, doctor?
Yes, just for non-pharmacological treatment, you can also advise weight-bearing exercises to
Exercise
improve,
always good for health for any way.
but specifically weight-bearing exercises.
But Dr. Huma, can you tell the high more body weight or less body weight is good for osteoporosis?
Oh, more body weight, definitely.
So
Less
fantastic.
body weight,
It is
low
a
BMI is risk factor.
yes. So is could be a different thing we have to learn today. Anyway, let's move now. So what you are looking here in the X-ray, please, Dr. Rita, comment please in the picture A. What is this? Quickly.
So this is fracture.
Name of the fracture. Which area?
So this is hands fracture. I think so. This is green. Lina must
No,
know.
no, there's another
No,
name. Who
no,
can
no.
say? Who can say? Who can say?
Colles fracture.
Colles fracture.
Yeah,
Colles.
Colles fracture.
And the
Fall.
B, and the B, picture B.
The vertebral body fracture.
No, it should
It's,
have a good
it's
name, doctor.
compression, sir.
Compression fracture.
Vertebral compression.
Vertebral collapse or
Vertebral.
compression fracture, rather. Yes. Then C. Neck of the
Neck of femur.
Then the neck of the hip.
No,
Hip.
femur? No, femur.
Femur.
femur. Is it femur?
Neck of the humerus.
Humerus. Humerus.
Yes.
And this
Okay.
one?
This one is neck of the femur.
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 Yes.
Yeah.
Femur.
Neck of
So,
the
so now you understood where are the osteoporotic fracture happens. What are the common location? Already you came to know now. Okay. So these are the areas where fractures happen due to osteoporosis. Okay. Is it good bone in the X-ray?
No, sir. Load.
Yes. It's a
Hmm?
good bone. Having
Somebody
no-
confused. Somebody telling somebody. Is it good? Any osteoporosis there?
No,
I think it's normal. I think. Looks
Normal?
like.
normal.
Sure?
Yes, I think
Yes.
normal.
Very right. Very right. This is normal spine. And now look at the picture. Is it normal? That means in the perspective of density, as our general practice, we are going for the X-ray first. For that better to us now. Is a normal vertebra?
Sir, this is
Looks
L2,
like
I
normal.
think. There,
Normal.
L2.
Normal. Yes,
Yes,
there
sir.
is a difference of our visual impressions. Man to man, it varies. Definitely, radiologist will be the good one to opine here. Now compare with the previous normal one.
There is a
Then you can
gap,
say.
more gap between the vertebrae.
Gaps are normal. I'm just asking about the
Density?
density. Compare here.
So there is low density.
Now you can say low density, but before you
Yes.
are thinking it is a normal.
Yes, sir.
So this is that puzzling thing. An X-ray can give the impression to us, and you know about the X-ray have some technical messages, meaning to us. Possibly those who attended our chest X-ray classes, you know that many important informations we need to know about the technical aspect of X-ray in the chest. Similarly, we need to know about some technical issues of the X-ray of the spine. But today it is not the topic today. Hopefully, if Almighty gives the chance, we will arrange a discussion on that day, the technical issues of the spine X-ray. But today, just you compare in the bone, the X-ray, comparatively the bone density is less. But I ask you, why you advise this X-ray, and you got this finding?
Sir, someone can present with the
Osteoporosis.
low
No,
back pain.
low back
Low
pain,
density.
commonly low back pain. We don't know that is there any osteoporosis or not, right?
Yes.
And if suppose technical thinking, if I like to say that if the radiation is too much, even these normal X-ray will be shown as such. Okay.
Yes, sir. Yes, sir.
So by looking the X-ray, practically we cannot directly say that there is osteoporosis or not porosis, rather osteopenia also very difficult to say. But at best we can say there is osteopenia because the bodies are black. Then we will ask the patients about the patient is in any risk factor for the osteoporosis. Then we will go for the which test? Next. If I
DEXA?
suspect,
DEXA.
then the bone mineral density test by the DEXA commonly.
DEXA scan.
Yes. Before the scan also, there are some, what I say, the rules or recommendation we like to know, we will know about. Now look at another picture. You see, these are the normal bone, but this is fracture bone. So more likely these wedge-shaped fractures, collapsed vertebra, more likely due to osteoporosis. Okay. Now again compare, you see, is it a little darker than the normal?
Yes.
Fine. Fine. What is the image name of this? What
MRI
image?
scan.
MRI.
MRI.
MRI. So these are actually not the bony tissue, though it took the shape of the vertebra. These are the fatty tissue, fats, bone marrow, and others in the bone. It is shown in the MRI. But what happened to the vertebra?
Sir, it's wedged and compressed.
Compressed fracture. So this is, it could be again osteoporotic fracture. If history is not that due to immediate trauma, okay, by accident or other thing. So some message for you now, I like to read for you that if an X-ray spine or hip shows low bone density, but dual X-ray absorptiometry scan is required for a formal diagnosis. What diagnosis? To diagnose osteoporosis. Decreased bone density can be appreciated by decreased cortical thickness and loss of bony trabecula in the early stages in radiography. Okay, and the bones like vertebra, long bones, especially the proximal femur, calcaneum, tubular bones, usually looked at for evidence of osteoporosis. So everybody should know about the message. Otherwise, where will you advise for the X-ray? Okay, now you already have told about the T-score. T-score means it is in comparison with around the age of 30-year people, normal healthy people, they have the bone density and they have the mean of the bone density. With the mean, we are comparing the T-score to diagnose bone mineral density. So normal value means actually this is the mean of young adult around the age of 30 years, young healthy adult. So this is the extension with this standard deviation as well. So normal bone density from here up to there. From here up to there. This is osteopenia. It could be a question in your exam. In which T-score defined as osteopenia, and this is osteoporosis. That means less than minus 2.5. And below is the picture. This is the normal bone and this is the osteoporotic bone. Very thin, fragile. Okay. And what are the causes of the osteoporosis? The endocrine cause, GI tract. Endocrine is very important, including the drugs as well. So one of the important is mandatory part of the life of human women, right? If she gets life, premature menopause could be there, or even the normal physiologic menopause also one of the risk factors. Hyperthyroidism, Cushing's disease, type 1 diabetes, hyperparathyroid. So many endocrine diseases are there. In the GI related, don't forget chronic liver disease, celiac disease as well. Why I mark chronic liver disease? I have some intention. These are common disease. Not only that, in the chronic liver disease, we have to be aware of drug advice. Okay. Similarly, chronic kidney disease, if relevant with any disease, again we have to remember. Suppose CKD in the lower part, you see, it is also risk factor for the osteoporotic fractures. So we have to give the treatment. So if the liver is in trouble, kidney is in trouble, we have to be very careful to select the appropriate medication. Okay. And other causes, I told you that endocrine medicine, especially letrozole, extremestane, you see, these are used in the obstetric practice. And the lower bottom one, what is written, doctor, in the red color?
Proton pump inhibitor.
Very important. Don't forget it, because whole world we are using this drug months together. Patients are taking years together. See, another cause of the osteoporosis. And how to approach now for the general practitioners. This is the general practitioners approach. So detail will be provided to you as PDF. So the main thing I like to add here, the main important keywords are, we have to consider the age, we have to consider the gender for the risk identification, especially age of 50 years and the age of 65, 75. That means up to 64, 74 means 65, 75. And here 84, 85 and more than 85. So these are the landmark of the age. In this age group, we are now by algorithmic manner, we are evaluating the patient down. But one interesting thing you see that wherever patient have the fracture already, then we have to start the treatment. For example, look at the right column. Those who are having the age more than 85 years, irrespective of gender, use clinical judgment to assess fracture risk. Clinical judgment, not by bone mineral density. If risk is high, start bone protection treatment without further assessment. So this is one of the very simple absolute indication, rather to say, without going to the BMD and other thing. Okay. So if age is more than 85, and remember it, please. And other thing is with the history and other, the lifestyles and others, then many yes, no, and they're going down. Regarding the FRAX, you can see the FRAX here. FRAX, this is the scoring system, digital scoring system. Another one is the Q fracture, commonly popular too, the FRAX and the Q fracture. And here in the FRAX, the calculation of the risk can be done by two ways. One way is with BMD, without BMD. That means without doing the BMD also, FRAX calculation can be done. And BMD also important. Then you will come to know by following the algorithm when you need to incorporate BMD with the FRAX. And Q fracture also you see the without BMD here. With this way, you can come to a conclusion that patient is in the low risk or high risk. So it is your job, my beloved colleague, you will read by yourself what those who are in the low risk, those who are in the high risk. Like the cardiovascular risk assessment, especially clinically significant risk is equal or more than 10% risk. In the 10% risk, we will consider advice. That means the medication, lifestyle advice, and others. Now come to the further informations that the do not request BMD without prior use of risk prediction tool. This is maybe a new message for you, for some of you in minimum. You have to go with the FRAX or Q fracture, then decide the risk of the osteoporosis, and then go for the BMD. And the FRAX will be without BMD measurement FRAX. And then if you calculate the significant risk, then go for the FRAX with BMD. Already we discussed before. So X-ray cannot be used to measure BMD. X-ray can give us an impression that patient might have low bone density. Okay. And this is the online software also, the Q fracture link. If anybody wants, you can check by yourself. This is the link. If you don't know or don't have, you can send request. We will provide you this link after copying. We'll paste in the group also. So you see, just look at that during the risk calculation, what we have to consider. Risk of osteoporosis, age, gender, ethnicity, smoking, alcohol, diabetes, many other questions. As we will provide you, no worry, you can see many chronic diseases are also here. Okay. And another one, this is the FRAX. Almost similar thing, a little maybe different. Almost similar thing, yes, no. And you put the data and finally button, they will give you that it may be 10%. You see, major osteoporotic is a 9.5%. Hip fracture chance 1.5. This is that possibility only. We are getting the message from there. Probability of the fractures are there. Okay. And they are not free. Q fracture is not free. I don't know today is free or not previously. The indication for the dual X-ray absorptiometry. So low trauma fracture. Low trauma fracture. Doctor, who can say about low trauma fracture? Another word is told as trivial fracture or fracture by trivial trauma. Yes, Dr. Homa?
Fragility fracture.
This is the same name, but can you explain more? What does it mean?
That means just, let's say for a simple fall, that results in a fracture of
Fracture. This is an example, very nice example.
Fall from a standing height.
Standing height also. It means usually healthy people will not have the fracture if the person falls from the standing height. Okay. But anybody have this fracture, then it will be significant. That means bone becomes weakened. This is the message. Bone become fragile. So this is that low trauma fracture. And other thing by calculation, if risk is more than 10%, glucocorticoid therapy, another risk factor. Okay. So like this, go down the age less than 50, but a strong risk factor for osteoporosis also. Strong risk factor means already we have shown that family history of fracture and others. On those situations, we will advise for the DEXA. It's a clinical information for you. But if you see any features, already we have shown to you that X-ray feature could be black bone in the postmenopausal lady. If you can accumulate many other risk issues, so if we see something suspicious to be osteoporotic in the X-ray of the lumbar spine or any part, especially the ends of the long bones, we can advise for the DEXA study. And in the osteoporosis management, we have to do some other relevant investigations. So already we have shown to you that there are different causes of osteoporosis, endocrine cause, other diseases, lifestyle issue. So if you can remember this thing, you can understand that why should we go for the renal function test, liver function test, CBC and others. You see the celiac disease, tissue transglutaminase. But we will not go for each and every test. As a clinician, if we suspect that patient might have one or two diseases from there, then we will go for. This is our learning. It is only book knowledge, not our whole action plan. Okay. And you already told osteopenia means -1 up to -2.5. In those cases, usually management is the lifestyle, not the medication. And repeat DEXA scan in and around after 2 years for the osteopenia. But if we give the medication, the follow-up plan is a little different, a little modified. Minimum 2 years, even it could be after 2 years also. And this is just physiology of the bones. Osteoclastic activity and osteoblastic activity. So if there is any imbalance and the balance, if more goes into favor of the osteoclast, then osteoporosis happen. I have shown it to you because there are medication, those who affect this procedure. For example, for the treatment purpose, if the medicine can stop the or reduce the activities of the osteoclast, it will be a good medicine. Theoretically, even if we think that if any medicine can increase the osteoblastic activity, then it may be a treatment of osteoporosis. So this is the simple thing. So now come to the principles of the treatment. Lifestyle is very important. So maintain body weight more than 19 BMI. So it is a reverse. Usually we advise people that lose your body weight, but it should not be not too much BMI 24, 26. Then more BMI, the far better. We better not to think. We have to think that the BMI should be more than 19. That's enough, including adequate intake of vitamin D and calcium. Okay. Regular exercise, stop smoking, decrease alcohol, as usual lifestyle advice. But this is a little exceptional about the body weight. And osteoporosis drug treatment indicated -2.5 in general. But whenever the fracture happens, if I don't know about the BMD, this is also indication for the treatment. Okay. If it is again the happen by the trivial trauma, fragility, fracture, whatever you say. Again, important issues of the glucocorticoid. Remember, and please remember, very simple thing and must be remembered. High dose inhaled steroid also can be hazardous. We are using high dose in the asthma patient months together. Okay. And the frequent courses of steroids, that means the oral steroids, frequent courses. And one thing also, if with a single course of prednisolone is 7.5 milligram daily or more than that, and patient is taking more than 3 months, it is also a risk factor. That means it needs the treatment of the osteoporosis backup. Did you understand, doctor? If you don't understand, please
So,
raise
sir,
hand or please.
if someone with Cushing disease, can we start at the same time the biphosphonate?
No. Cushing disease, we don't think that this is causing the osteoporosis. We will be treating the Cushing disease. It is a reversible one, right?
But with
Repeated.
the
But yes,
prednisolone.
no, not medication. If patient have the fracture, then we can consider. But our job is to exclude the osteoporosis by BMD study.
Okay.
Okay, go for the BMD, then decide to treat or not. And the steroid, already I need to repeat actually. If TS score is less than 1.5 also, we have to give the treatment. Okay. But what they are telling in your GP book that you better to refer the case. You understand, you know, even then for competent treatment in the refer if TS score is less than 1.5, bone protection treatment should be given. But if it is more than any case, more than, not more than, actually better to say less than, it is a negative value. So less than minus 2.5, you can start the treatment. But my beloved GP, and even from my native country or other countries, whenever we need to start a little complicated medications, we need to be much confident about the medicine, the therapeutics of the medicine. Indication, not only contraindication, monitoring, side effects, how to tackle the side effect. If you don't know, actually better not to start any medicine in any disease. But nowadays, I told you, the osteoporosis treatment actually took its own bright light nowadays. For this reason, a GP can enlighten themselves about the osteoporosis treatment, so you can start. Better to be, the patient should be dealt very confidently. Okay. About the bisphosphonates, the different dose and others, but message to be used. It is more important to be known. The first thing in the morning, more than 30 minutes before food or other medication. Remember, it should not be mixed with other medicine. It should be singly to be taken before food, minimum 30 minutes. And patient should take it in the upright position. So patient better not to go to the bed minimum up to 30 minutes after taking. So minimum 30 minutes before taking, minimum 30 minutes after taking. We have to give the
Sir?
advice what patient is to do. Yes, doctor.
Sir, I have a question. As you have mentioned, this medicine should be taken first thing in the morning, 30 minutes before breakfast. So, sir, as is the case with levothyroxine, patient with hypothyroidism, they need to take the medicine early in the morning, 30 to 40 minutes before their breakfast. So, sir, in that case, how do we advise for medicines?
You can calculate your own time for your patient. It should be 1 hour apart. Okay.
Okay,
That
sir.
means better not to be mixed with the other medicine. Even the thyroxine also better not to be mixed with other medicine. For this reason, the patient is to spend minimum 2 hours, to take those medicine. One thing. Another thing, thyroid medicine can be taken at the night time also, not in the morning. So you can advise that, okay, take these bisphosphonate in the morning, thyroxine at the night. Okay.
Okay, sir.
This is
Okay.
possible. That I told you that therapeutics should be much clearer to us, only not to advise the medicine. So now the very technically important thing is how to select appropriate anti-osteoporotic drug. Okay, already you have said that bisphosphonates, there are some other than bisphosphonates associated with the auxiliary medicine is the vitamin D and the calcium. So before selecting, what we like to know? We like to know first thing is which is the background of the osteoporosis. One background is post-menopausal osteoporosis. It is a very common group, those who are affected. Another group, glucocorticoid osteoporosis, maybe male, maybe female. Another one, male osteoporosis. That means the medicine is not equally suitable for the male and female both. All medicines are not equally effective. For example, we try to give you an impression by marking that all the medicines are effective in the postmenopausal osteoporosis, glucocorticoid osteoporosis, and the male osteoporosis in the upper part. Just to make it clear to you, we marked it. If you come down, you see, abaloparatide, romosozumab, many other names, hormone replacement therapy. You understand the hormone replacement therapy is actually nothing to do for the male osteoporosis. Raloxifene, even the tibolone. So these are not used for the male. These are not used for glucocorticoid osteoporosis. So for the postmenopausal osteoporosis, now you can summarize that all medicines are working well. This is one message. Clear now, doctor? Somebody is to better respond my question. Otherwise, I will think that I am talking singly. Nobody with me.
Yes, yes, sir.
Okay.
Yes,
Clear.
sir. Yes, sir.
Okay. Now come to the next message. Which drug works in which place in the musculoskeletal system? You see that in the, I will not tell each and everyone. You just take one example. The alendronate work in almost everywhere. Hip fracture, vertebral fracture. That means the prevention of the fracture, even the non-vertebral fracture. But if you come to the zoledronate, again, if you select the injectable, zoledronate always injectable. They also work in the three places, these three headlines. But come to below, somewhere it is written minus. Even in the above also, ibandronate, very commonly prescribed. But you see, the evidenced area that the ibandronate will work more in the vertebral fracture, less or minimum in hip fracture, in the non-vertebral fracture plus minus. If you or I myself don't know this information, what I could do? I will advise ibandronate for each and every patient of the osteoporosis. Wherever it is vertebral fracture, wherever hip fracture or non-vertebral fracture. Non-vertebral you understood, doctor, Colles fracture and other I have shown to you before. Clear now, doctor?
Yes, sir.
So this message also important, that which area, which drug is important. So we should have this data in our hand before prescribing. And better not to remember, because a GP is not prescribing this medicine every day. You might forget. So if you have, it is very good. If you don't have, you will preserve this slide, doctor, with you in your mobile phone also minimum. Otherwise, better not to advise. Okay. And these calcium, vitamin D, you see, for the prevention of the fracture, almost no value, but it can give additional benefit. Calcium and vitamin D, it helps some to prevent the fracture a little, but not significant. How to make a follow-up plan? So again, in the follow-up plan, we need to know what medicine we already advised. Is it the oral or the parenteral? Okay, you see, the follow-up means we will go for the BMD review, remember it, and we will ask clinically many other things. So if it is oral, the follow-up plan, follow-up BMD will be after 5 years. It is in and around. And if it is injectable, BMD test after 3 years. But before I told you, in the patients of osteopenia, review the patient after 2 years. So this review is your job. You are the GP. It is not the matter of a specialist. So those patients already on the treatment or those patients having only osteopenia, so follow-up plan should be like this. Now, after doing the BMD, if you found that BMD normal, then you can stop the medicine. But BMD is not good. After oral medicine and you have evaluated after 5 years, you found that BMD is still not in the good value. So further 5-year minimum we have to extend and follow up. But regarding the injectable, the data is not clear. How many years after we have to do BMD again? I am asking you, with your general experience and understanding today, after how many years you will do BMD again if patient is on injectable, please? Anyone? You tell your personal opinion. Dr. Rita?
2 years, I think.
Yes. Dr. Javed?
3 years.
I am also with the same opinion, really 3 years. But suppose guideline, recommendation may be varied. Okay? And BMD should not be done earlier than 2 years. If you think that I can do a little earlier. So for this reason, try to remember this simple 3 year, 5 year, 3 year, 5 year, 3 year, 5 year. Now, the side effects of the bisphosphonate. You already told your patient to take this medicine in the morning, 30 minutes minimum before food, and keep body upright minimum 30 minutes, so and so. What was the reason, doctor? To prevent?
Sir,
To prevent?
dissolve.
Not for dissolving. To prevent
Yes.
which side effect?
Esophagitis.
Esophagitis. So we are letting the drug to go down earlier to the stomach and to the duodenum. This is the esophagitis. But there are some little rare side effects we are showing here. It is called osteonecrosis of the jaw. Patient may come with the jaw pain after getting the tablets, not tablet, especially if it is given in the parenteral form. Parenteral form. Okay. And it needs surgical excision, doctor. So how dangerous it could be. But I am not giving you the fear, or I am not spreading the fear to advise. It is very rare side effect. Many drugs we are using with many dangerous side effects. So don't worry. Just to let you know only. And your job, advise the patient for the regular dental checkup, or minimum tell the patient if you have any pain in the jaw or other, please inform us. Okay. Fine. Another one is called atypical femoral fracture. Just to remember these two words, osteonecrosis of the jaw and atypical femoral fracture. You are giving the treatment for prevention of fracture, but osteoporosis can cause femoral fracture, but it is atypical. Maybe controversial, but it can happen due to the over suppression of the bone turnover, and if the treatment is given more than 5 years. For this reason, doctor, now you understand why after 5 years we have to evaluate the patient by BMD, because this is another risk after 5-year treatment. So preferably after 5 years, a drug holiday of the 1 to 5 year has been proposed. Okay, after 5-year use, drug holiday. That means this osteoporosis treatment actually a long-term treatment. Long-term treatment. And these are the list of the adverse effects of bisphosphonates. These are very common. And one thing you must remember, and I also face this with some patients, acute phase response. It is a relatively common. Another one, upper GI intolerance, already you have mentioned, and you already advised to prevent this, esophagitis and others. But for the intravenous use, the GI irritation is very less likely. But remember that even give the intravenous also, it can cause irritation of the esophagus. It is a book knowledge I am telling. But intravenous use specifically causes acute phase response, fever, shivering and others. So we have to assure the patient, don't be afraid. And it is fact that these intravenous issues, the intravenous causing the acute phase response, usually happen only for the first time. Usually it does not happen in the subsequent time. That means after 1 year, if you think about the zolendronate. Other intravenous given not yearly, maybe after 6 months or 3 months, 1 month like that, 3 months rather. But I'm telling about zolendronate because personally I'm using zolendronate for this reason. I'm telling more after 1 year. And less common, atrial fibrillation, intravenous zoledronate. So it is also, it may be dangerous, no doubt, but definitely transient. And you, if you know about the atrial fibrillation, you have attended also before in our cardiovascular disease. If the atrial fibrillation may not be always dangerous. It is also true. It may be for the time being after zoledronic acid, just to keep the patient under watch. Okay, and it is also true that is very less common. It is not happening everywhere. Okay, and atypical subtrochanteric fracture, already we mentioned before, atypical fractures. And other rare is uveitis, that means the involvement of the eye. Okay, so as a GP, minimum we shouldn't forget the common side effect, and keeping in the mind the common side effect, we have to give counseling to the patient, explanation. Okay, this is the transient influenza like, that is acute phase response, occur within 1 to 2 days, 24 to 48 hours. Practical message, doctor, must be remembered. And this is self-limiting. We can use paracetamol and the NSAID because patient might have body pain and the fever. And usually occurs after the first exposure, and later on tolerance develops. So it will not happen, usually will not happen after the first exposure. Hopefully clear to you, Dr. Namas, right?
Yes, sir. Yes, sir.
Yes, sir.
After this bisphosphonate, come to the denosumab. It is a monoclonal antibody, decrease osteoclast activation. So it will be a good choice. Usually it is selected as a second drug. Second drug means the second choice, not the first choice. Okay. But unfortunately, my observation with my surrounding practice, I'm sorry to say, I don't know what situation in your own countries, some practitioners of different specialty, they are advising denosumab for the in the first instance. But I am in doubt that did they think about the indication of denosumab or not. Might be they are thinking it may be a good drug given only once in a 6 month. Okay, whenever we understand sometime though wrongly that the cost is more mean efficacy is more somehow. So it is my,
Tolerations are tolerated by the patient.
might be, but it is indicated when bisphosphonates are contraindicated or not tolerated, and in the severe osteoporosis can be used for women with severe CKD. It may be choice if patient have CKD. Okay, and now come to the raloxifene, not recommended for primary prevention of osteoporotic fractures. Primary prevention means patient did not have fracture, only patient is in risk. On that time we can use. Okay, avoid if past history of DVT. This is the word. Maybe around when I was actually learner before my exam, then there was a discussion about the raloxifene. Maybe the trade name was Evista. Evista in the Western world or the Middle East maybe. The raloxifene may be marketed at that time. That was the talk of that DVT or embolism is a risk factor, the risk after using raloxifene. Okay, so better to avoid this. And even undiagnosed vaginal bleeding also contraindicated. But these are not usually practiced. We practice bisphosphonate, and bisphosphonate. Now come to the HRT. Okay, how many years we will use HRT? Not clear. Uncertain, 5 to 7 years or how many years. And the benefit disappear within 5 years after stopping. So the benefit is limited because we need to stop the HRT also. Not HRT usually not be advised for postmenopausal symptom and other beyond 5 years. So what benefit we are providing? Very limited benefit we are providing with the HRT. But HRT can be used for its own indication, not for the osteoporosis. Okay, it will give added benefit in the osteoporosis, but especially premature ovarian failure. that means the premature menopause. This is important indication for the HRT. Okay. Now about the premature already I mentioned, right? HRT or COC is recommended. You understand the COC, right? Combined oral contraception for the prevention of osteoporosis until women reach natural menopause age. It is important message. Natural menopause age, for example, maximum 51 year. Okay. So now 50 more than 51 year, HRT should not be considered first line. So these age also to be remembered. So these are very simple messages, but I believe that if you didn't hear about these, it may be difficult, may be complicated, but after the class today, hopefully it will be easier for you.
Yes, sir.
And the third line, teriparatide. It is a parathird hormone-like material, huh? Teriparatide. Maximum duration of use is 18 months. So third line for the postmenopausal, and second line for the man with the past history of fragility fracture. If other treatment are not tolerated or ineffective, like this, that means it is a later line, not first line. Teriparatide. Now the message for you: osteoporosis in men. Bisphosphonate and teriparatide is recommended in the men. I like to repeat: bisphosphonate and teriparatide, not other medicine. Recommended for men to treat osteoporosis. Monitoring, follow-up, already discussed in before, but repeating. No consensus. I already told you that actually this is weaker information with us. Even then, 3-year, 5-year, 3-year, 5-year we discussed before. And the DEXA scanning might be necessarily repeated. Fragility fracture on treatment. That means again fracture. If considering a change in treatment, you are thinking that medicines are not working or medicine become intolerable, we have to switch to the another drug. On that day, we can repeat the DEXA scan. And when considering restarting therapy after a drug holiday, already we discussed about the drug holiday after 5 years, we have to give some holiday. Drug holiday means suppose yearly injection, we will not give 1 year, 2 year. So before starting the drug holiday again, we can do a baseline DEXA on that time. So these messages was not too much clear before. Nowadays, I think you could have now a guideline. I'm telling you, the guideline means the dictation for you, the pathway for you, how you can proceed with your patient. When will you refer? As a GP, this is a set out information. Another cause of fragility you are thinking, for example, metastasis. That means a cancer. Definitely we have to refer. Fragility fracture on treatment, refer. There is a category of referral, you understand: urgent referral, routine referral. Unusual presentation of osteoporosis. That is the premenopausal woman. For consideration of the treatment of IV bisphosphonate. That means any other IV drug, denosumab or teriparatide. Okay. So now I am just what I say, criticizing myself, as I am with you now as a family physician. I am talking, but I am practicing this IV bisphosphonate. So actually, am I doing as pure GP, doctor? If it is a matter of referral, what do you think?
Sir, it should be in secondary care.
Yes. So I told you that I am practicing this IV zoledronate. So I am actually not performing my duty as GP. I am performing duty as a specialist.
Yes, sir.
In that respect, it is justified because by the mercy of Almighty, I am qualified to practice as a specialist. So there is no problem. But
Yes.
those who are pure GP, it is said that better you refer in such cases. But this is not hard and fast rule, considering the feasibility, availability, many other thing in, especially in the South Asian countries. Okay. But keep in the mind the referral knowledge. If possible, you can refer nearby your practice area. So these are the situations for the referral. So these are very basic thing, and the later on we will discuss some patients. So up to this now, doctor, please, if I miss anything, please help me. You can share. You can ask even the question also to me. If possible, I will try my best to give the answer. Anyone, please.
Sir, this zoledronate IV, can we dilute or it's direct ampule or what?
It is not your matter too much. If you advise it, if any diluent is there, the nurse or brother, they will give the dilute after dilution.
Okay.
So what will be diluted or not, it is actually, it is not very critical message, because some drug is needed to be diluted, some are not. Okay. For example, as you raise the issue, the therapeutic issue, what is the ceftriaxone injection? Very popular, right? In the few decades we are using ceftriaxone. If you advise 2 gram, it should be given after dilution by the drip. Okay.
Yes.
But is
Yes.
the less than 2 gram, it can be given direct push, but slowly.
Okay.
But how much about the medicine you can remember if you don't practice regularly? So what is the solution? Whenever you are advising any new medicine, you just go through the pharmacopoeia, okay,
Okay.
drug
Okay.
directory, to be confident. Don't advise anything by confusion. For example, even the zoledronate and other whatever, if you even the practice one time, you will never forget almost. So for
Yes.
any medicine, better not to ask that should I give dilute after dilution or not. You just look at the book. Books are available in the internet and manywhere. Okay,
Okay.
fine. Doctor, any other one?
Sir,
Any
can
other?
you tell me about the frags? Actually, I have no idea about the frags.
Frags is an digital internet-based calculation device. You know about the
For
calculation of,
BMD?
for
No.
yes, no, risk of the fracture,
Ah, okay.
risk of the, like cardiovascular risk. We are calculating 10%, 15%, is not it?
Yes, yes,
So
yes.
by the fracs, we are calculating the percentage of the risk of the fracture.
Okay, okay. Thank you, thank you.
Similarly, there is a Q fracture, another device. There are many
Yes,
other. You can search the internet, you can see, but two popular are Q fracture, fracs. Another one is the Q fracture.
yes,
They are considering age, gender, family history, many lifestyle, SLE, rheumatologic disease, body. You already understood, heard about the BMI and others. That's
yes.
so now thing is that before advising BMD, we have to go for the fracs or the Q fracture. That means the risk identification. Then go
Mm,
for the BMD to start the treatment.
mm.
It will be useful. So with this introduction now you get ready, doctor. I will be happy if any new colleague today to discuss the patient, right? New colleague, I know many of you today. I'm happy to know all of you, but maybe new colleague, those who didn't show the name, I'm sorry, I cannot utter the name. Now, first patient, who want to read?
So
Dr.
may I?
Nawaz, I think always ready.
Yes,
Who?
sir.
But
Yes,
Dr.
sir.
But any
Six.
someone responded? Who? Other than
Yes, sir.
Dr.
Me,
Dr.
Rita.
Rita.
Yes.
But what about other Dr. Huma? Maybe relatively newer today. Dr. Shazia. Shazia. Some are only hearing my voice, not responding. I will be very happy if you respond, interact. Any colleague other than? So, Dr. Rita, please, as you responded first.
Yes, sir. A 66-year-old female recently had a chest X-ray because of troublesome cough. On reviewing the report, the lung field are clear. However, the radiologist mentioned an incidental finding of osteopenia in the thoracic vertebra. Her cough has settled since last seen you and she has no particular complaint. She is not on any regular medication and went through the menopause aged 52. What is the most appropriate management plan?
Okay. So, could we think that the patient might have fragility fracture?
No.
No. Why no? Age is 66 years, advanced age. Okay.
Menopause 52.
This is menopausal, no doubt. Again, the 64 or 65 is the medium category of the age range. This is a female one. Second, lung feels clear, no respiratory disease, but patient is coughing, pressing over the bones. So patient might have fragility fracture in future, not now.
Hmm.
What is the clue? Because radiologist opined that patient is having osteopenia in the thoracic vertebra.
Hmm.
So cough again is a risk of fracture, is not it? The force,
Yes,
energy.
force.
So if patient have persistent cough, patient may have rib fracture. I think it is not very rare in our clinical life experience. If you those a little senior today, you can remember in your student life or postgrad life, patient might have this rib fracture due to only by the violent cough without any trauma. So this is also if the fracture there, it could be an example of the fragility fracture. Anyway, you are suspecting osteoporosis right now. Minimum doctor,
Yes,
I told you, whenever you suspect osteopenia in the X-ray, our job is to go for BMD.
but
Okay,
yeah,
okay, BMD. But now choose your answer. Will you go for the BMD or will you go for the DEXA? So sorry, DEXA is the for BMD, or will you go for the frax or Q fracture? Is there any option?
no any option like
No,
that,
any
no, sir.
option. So
The
I think
X-ray and
so you will go for the DEXA. Maybe outright answer. But is there any best option other than this? Choose and give
Start
the answer.
bisphosphonate, sir.
Start with first one. You will start the treatment.
Yes, sir.
before
What is your reason, doctor?
Sir, it is very clear from the scenario that already the radiologist have seen the patient. There is confirmed osteopenia and there are risks.
Doctor, uh, why you are telling confirmed osteopenia? Confirmed osteopenia after BMD only.
Okay, sir.
It is not confirmed. It is suspected. One. Second mistake, sorry to say. The indication of the treatment is osteoporosis, not osteopenia. Okay, doctor.
Yes, sir.
Malum. You understand
Yes,
Yes, sir.
yes.
malum?
Yes, sir.
So,
before
so,
DEXA scan.
so
Sir,
what
what
will do?
about the age? Age is 66 years.
These are the risky age, doctor. Age is in
Yes.
the risky age. Risky means patient might have osteoporosis. Might have, I'm not sure. Okay, we have to be confident. So, DEXA is the diagnostic test for the osteoporosis.
Hmm.
So I think I think now already without showing the answer, we already told the answer.
Yes.
Refer for DEXA scan. So this is your exam question. We have to answer in this way. Okay.
Hmm.
So if you start the treatment and other thing, it will not be the best option or best choice according to the guideline or recommendation. So this is very big algorithm, doctor. I will share with you later. You will go through by yourself. Okay. And we tried our best to give you the text with the different color and other. So it will take very long time. Those we discussed, these are summarized. And it incorporates the specialist evaluation process also here from the medicine book. We have collected it. One thing to add only here that you see DEXA scan here to give you further confidence. Patient have the fragility fracture if we evaluate this. So if the fracture is there, the recommendation is to start the treatment. Okay, without going for the BMD also. But why it is BMD again done by the DEXA here? Who can say? Here, there is a fracture. So before starting the treatment, in between, you are going for the DEXA. It is a baseline value. Clear?
Yes.
DEXA scan advisable to obtain baseline BMD, but not necessary to initiate treatment. Your already treatment indication is there. Fracture is indication for the treatment. Fracture means fragility fracture, low trauma fracture. So this is only for the baseline. But in the risk assessment process, DEXA are done for the diagnosis of osteoporosis. Clear?
Sir, can I ask a question?
Why not? Why not?
Sir, go a little bit on the question.
Previous patient.
Yes, this one.
Okay.
Sir, we are here suspecting now that this is osteoporosis.
Yes.
So why we are not doing other X-rays? Means for the pelvis is fine.
Oh, the X-ray features is not suggestive for osteoporosis.
Oh,
Okay.
it will suspect just
Yes,
osteopenia.
yes, 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 yes. And I already told you some technical issues also. If the radio technician gives additional rays, it can show the darkness in the bone, though bone is normal. I'm just telling some technical limitations. And efficacy of the investigation, where is one to another one? Okay. So established decision is to diagnose the osteoporosis. The test is BMD by DEXA.
Sir,
Yes, yes.
sir, we will start treatment on the basis of osteopenia,
No,
isn't it?
no, no. We will not start the treatment. You are referring the DEXA. What is the reason? Just to diagnose osteoporosis or not. If it is osteopenia range of the T value, you will not start medicine. You will give
Okay.
lifestyle advice only.
Okay, okay.
Okay.
Right, sir.
Don't think that referring DEXA here is only for a baseline. This DEXA to diagnose the osteoporosis, not baseline, because this is only osteopenia there. There is
But we
no
will start
fracture.
treatment.
Doctor, just to add, if the patient have fracture in the ribs, for example, by the cuff, without any other disease is there, okay?
Right,
That
sir.
means the what is it, the fracture of the ribs or other, for example, I'm not telling the vertebra, or somehow even the vertebra. So this is abnormal fracture. In this situation, DEXA be done for the baseline value. But if there is
And
no
sir,
fracture, DEXA should be done for osteoporosis diagnosis. Please, Dr. Shazia,
right,
any other thing?
right, sir. And sir, if there is osteopenia on the basis of DEXA scan, then we
Yes.
will start preventive treatment.
Yes, yes. I will show you also later on. This is a lifestyle advice. Lifestyle advice. Osteopenia does not warrant medication, but exception is steroid. Steroid induced osteopenia. I will show you. So lifestyle advice very important. Not the best answer diagnosis osteoporosis. Anyway, they are discussing this. Already we discussed it. Hormone replacement and others. Better to go with the next patient. Who want to read? Hopefully Dr. Shazia. You
Right,
open
sir.
the mic. Okay, carry on.
A 78-year-old woman is discharged following a fractured neck of femur. On review, she is making good progress, but consideration is given to secondary prevention of further fractures. What is the most suitable management?
Hopefully everybody can answer now, please.
Start biphosphonate.
Very straightforward. And any other colleague, any different opinion? Please look at all the options. So Dr. Nawaz's suggestion for you, possibly it may be the answer, for example. Even then, you need to check other options. Is there any technically different message or not? Okay. Other colleagues silent. That is the same opinion. The keywords.
Why not D?
Yes, why not D? Dr. Nawaz, why not D?
This is already fracture a neck of the femur.
Yes.
So no need.
Clear now, doctor? Already fracture is there. 78 year. Okay. So question is to secondary
Prevent.
prevention of the further fracture. So fracture already happened. To prevent the further fracture, we will go for the straightforward for the treatment. No DEXA here. Okay. The fracture itself proved that there is underlying osteoporosis.
Sir, we will start treatment after osteoporosis.
No,
DEXA scan
no, doctor. This is that interesting thing. The fractures itself proving that patient have
No, sir,
osteoporosis.
sir, not in this case. Sorry, I am disturbing all the
No
people.
disturbance, doctor. This is a
Sir,
discussion.
not in this case. Just on a general view, if we get osteoporosis on DEXA scan, then we will start. Then we need to start oral
Yes.
bisphosphonates.
Yes, yes, yes.
But not on the basis of osteopenia.
No, not on the basis of osteopenia.
Right, sir.
Sir, one more
Please,
question. Sir, is
please.
there any fracture, but the age is less than 65? So what we will do? We will start breastfeed or
Again, remember, not only 65, even the age less than 50 also. We have to consider the fracture is due to low trauma fracture, trivial fracture, like this. The history is important. Okay. Now,
okay.
And then DEXA
no,
scan.
no. Now again, you can think like me also. Okay, I am not much confident about the nature of the fracture. That means the causation of the fracture. For example,
Mm.
somebody telling that my child or someone fallen from the building roof, but roof is not too much high, okay,
Mm.
or on the side wall of the field. So you are confused. Understand?
Okay.
At that time, how will you make a decision? At that time, you will go for the BMD, then decide.
Mm.
Clear?
Depend on the
Scenario. But if you're very confident that patient was in the inside the house and fallen by the simple sleep attack in the ground from a standing
Mm.
height, suddenly fracture. Usually happen in the Colles fracture in our elderly ladies, grandma, right? They are
Yes.
supporting with the hand on the floor and fractured of the hand, the wrist, Colles fracture. So if a very typical one, in those situation, don't go for the BMD. Okay,
Start breastfeed.
but
Yes.
BMD done for the comparison, not to start the
Mm.
treatment. Clear now,
Mm.
Dr. Shaji and other?
Yes, sir. Yes, sir. Thank you, sir.
So again,
But
this thing,
comparison for the later, after
yes,
the treatment.
after 3 year or 5 year. If you start the oral, is a 5 year. If you start with the parenteral, after 3 year. For
Right,
this,
sir. Thank you.
for this reason, doctor, my experience to share with you may happen in your country. Our laboratory owners, the businessmen, are not establishing DEXA measuring instrument in their business. Understand now what is the reason? Because it is a business of the 3 year, 5 year. I am with this environment working, and somebody started this, and sometimes you stop because the business. But they are having the regular X-ray machine everywhere. Now you understand the business point. Okay.
Um,
There are some other drugs. Okay, the patient over the 75 are many without the need or DEXA. Already we discussed maybe in short. Another drug is strontium ranelite, no longer recommended. Okay, for the cardiovascular safety. A lot of discussion there. Just I tried to give you some important highlighted messages. General points about the management of all patients. Secondary hormone replacement therapy for me, primary. Doctor, anyone to tell something?
Sir, I have a question.
Please, please.
If you have a case of suspected fragility fracture, is it necessary also to exclude any pathological fracture, like bony mets, before you start bisphosphonates?
Why you are using the word pathological fracture or fragility fracture differently?
No, I mean, is it because there's a possibility in that age group that
Yes.
they
If you
may be
say,
pathological fracture.
sorry, doctor, to interrupt you. If you think or I think that my patient have the low trauma fracture, I am meaning this is fragility fracture. But if I say
Right.
that any malignant deposit in the bones causing the fracture, it is also one kind of fragility fracture, reason of the fragility fracture. But
Right.
if I suspect any malignant disease underlying, definitely I will go for the investigation of the cancer,
Hmm.
maybe in the chest X-ray or other. But
Okay.
patient needs bisphosphonate. Clear now? Patient need
Right.
bisphosphonate plus treatment of the primary cause.
Oh, right. So,
But
thank you.
here we are discussing actually the primary, rather to say primary osteoporosis. That means the problem in the bone only, not due to other cause or other disease, malignancy or other. Okay, fine. So just to remember, already we discussed this other medicine. And now giving you little clinical scenario, fragility risk fracture assessment. That is a for whom actually we will assess the risk fracture. Already we discussed by the Q fract, the fracts of the Q fracture risk. Better go up to the next one. So requesting someone to read it. Premenopausal women. Okay, you can see postmenopausal women and men aged more than 50 years who are treated with oral glucocorticoids. Do you understand what I mean? A scenario that is a patient postmenopausal women and the man more than 50 years who are treated with oral glucocorticoids. This is the clinical background. Will you give any treatment? Dr. Rita?
Yes.
Already
Yes,
answer.
Yes, sir. We will.
Already
Yes,
answer
sir. We need
shown.
to give
Already
treatment.
answer shown. Already answer shown. But sorry, technically I am wrong. I could make it hidden. I couldn't do. Understand? Answer is shown here. Especially, it depends upon the dose. I already told you. If the starting 7.5 milligram per day prednisolone or equivalent other steroid for the next 3 months, they need bone protection. Bone protection means bisphosphonate.
sir, that is what I was discussing with you earlier.
Please, can you
When
repeat?
someone with the Cushing's or a bronchial asthma will take the prednisolone, so we can start the protective treatment or not?
Then the taking the steroid and the Cushing is different thing.
Yes, yes, yes.
Steroid may be a cause of Cushing, but Cushing may be due to pituitary disease.
Yes, yes,
If
yes.
you identify the Cushing pituitary disease earlier, if you remove the tumor, treatment is finished.
Yes, yes, yes.
In those cases, you can go for the BMD study. Actually, I told you we are not discussing the secondary cause of osteoporosis much today. For this reason, I am not going there, this area. For example, I told you that other colleague, Dr. Homa, about the malignancy related something, bone issues, even the osteopenia. Then we have to go for the evaluation of the primary disease, including the osteoporosis. It is right. Now come to another one. In this scenario, the prednisolone in that one we have to give general management, lifestyle and other. Don't wait for DEXA scan. Clear, doctor?
Yes.
Sorry, it was not answer. Actually, it is in the background. I'm sorry. Possibly I was wrong to say before. It is the background of the patient, including the drug history. So don't wait for the DEXA and start the bone protection therapy. Okay. So actually, I need to correct the slide in this way. Sorry, doctor. Right, Dr. Nawas?
Yes, sir.
Actually, this is that. This is that. Okay. So going to the next scenario. Dr. Nawas, can you read it?
Yes, sir. A postmenopausal woman or a man age more than or equal to 50 years has a symptomatic osteoporotic vertebral fracture.
What will be your treatment plan? Please, anyone to say. Dr. Anoshia Nabi, new colleague today maybe. Can you answer now? Those who followed the lecture from the beginning, anyone please try to give the answer in this background.
Yes, sir. It's
Menopausal,
oral alendronate.
more than 50 years, symptomatic osteoporotic vertebral fracture.
Bisphosphonate.
Yes.
Medicine is the bisphosphonate and general advice as well, right? Straight
Yes.
away without going to DEXA.
DEXA.
But actually without going to DEXA, again no. DEXA for baseline value. Isn't it?
Yes, sir.
DEXA for baseline value. But I like to add you, doctor. Don't take it otherwise. If any colleague oriented with the orthopedics, don't mind. I'm just telling observations. In the orthopedic fracture, Are they fragility fracture? No. These are the trauma related fracture, right? Road traffic
Yes.
accident and other. But interestingly, they are using the bisphosphonate randomly. It is not the indication of bisphosphonate. Bisphosphonate is for osteoporotic fracture. Okay. If you go through your hospital or surroundings, you can observe there. They are using, I don't know what their indication for the bisphosphonate. This fracture is actually the fragility fracture.
Sir, I have seen this many a times in the hospital, and whenever I ask them to, sir, they say that we are giving the medicine just to increase the healing. No, sorry, reduce the healing time, sir. They say that if we will add the bisphosphonate, so the patient will recover quickly.
This is
It will
that,
help.
this is, yes, I think that our colleagues also here will tell the same. But everyone search in the internet, very authentic source also, just ask a question. Can bisphosphonate reduce the healing time in the orthopedic fracture management? Then check the answer. If somebody is telling, it will not be the evidence. Only telling is not the evidence. Theory is not the practice. Okay, doctor? I didn't see. If you check only indication of the bisphosphonate even in the book, is there any indication of the bisphosphonate in the orthopedic practice? In which are
Sir,
those?
but they are all specialists who prescribe this medicine.
Doctor, specialist and GP, what is the difference between you and them? If you, I told you always I'm telling, be a confident GP. Be a confident GP. Don't think that you are inferior. Okay? The
Yes, sir.
specialist means they know about the subject in specific topic more than you. It doesn't mean
Okay.
that in generalized they are better than you.
Yes, sir. Very true.
Remember it. Remember it. And it is very true. I like to say, and I can, because I am a specialist as well as GP together. Okay.
Okay.
So don't think what they're telling. This is a reference. I'm sorry to say. The sky is open now to us, right? The sky is open. You just search there. They will give the message. Okay. Come to the next one. Hip fracture in older adults. Okay. In older adult with the hip fragility fracture, what you will do now?
Bisphosphonate.
That means straight away you will start the treatment.
Medicine.
Yes. Again, BMD should be measured as
Baseline.
baseline. And in the hip, some author, it is another authority telling that in the hip fracture, especially zolendronate is better. Zolendronate is better. Though it may be a decision. Already I told you, any parenteral treatment according to the guideline or suggestion to be given by the specialist, not by GP. But in your area, practically you can practice. Okay, for the parenteral. Then come to the next. Dr. Huma, can you go through with the patient now? Dr. Huma?
Yes,
Please,
sir.
please.
A 67-year-old woman comes for her medication review. 3 years ago, she was started on alendronate after sustaining wrist fracture and subsequently being diagnosed with osteoporosis. She asks you how long she will need to take bone protection therapy. What is the most appropriate time to assess her risk and consider the need to continue treatment?
Already discussed. So,
At 5 years.
5 years.
C.
Dr. Huma also the same. 5 year. Is it oral or parenteral medication?
Oral.
Oral. So oral means 5
5
years.
years.
5 years. So now you come to know how to make a follow-up plan, right? After
Yes, sir.
5 years. This is a slide repeated now just only. Okay, these are some guidelines. The guidelines, when the guidelines important, whenever the evidence are not too much strong. Okay, sometime guideline can help. Maybe the best evidence-based things are there. Okay. Sometimes patient need lifelong treatment. You see, patient may require lifelong treatment sometime. But keeping in the mind that if I give the treatment more than 5 years, there is a chance of atypical femoral fracture. Monitoring, already we discussed. General suggestion, lifestyle and others. Okay. Little clear guidance from major guidelines. Even then, we should have a pathway to proceed further, right? Okay. And one side effect of bisphosphonate, remember, is hypocalcemia. It is true, but we are using these message in one specific situation by giving parenteral bisphosphonate. Who can say? That means to lower the calcium in the blood rather early, immediately. We are giving bisphosphonate, especially pomidronate. Which clinical background? Malignancy associated hypercalcemia. Now you understood?
Yes.
Because bisphosphonate causes hypocalcemia. For this reason, we are using therapeutically in the malignant patient. Malignancy associated hypercalcemia. So what Dr. Huma said before also, malignancy causes bone fracture. Malignancy causes hypercalcemia. So is there dual benefit of bisphosphonate?
Yes.
Yes, one thing. Another clinical clue. If I treat the osteoporosis by the bisphosphonate, should I add calcium supplementation?
No.
No.
Yes, yes,
Yes.
yes,
Yes.
Yes.
Because of
Yes.
yes. Because
It
bisphosphonate
causes
cause
hypocalcemia.
hypocalcemia.
Hypocalcemia, but okay.
Now clear? So whenever you advise alendronate and other, give in our South Asian perspective, calcium and vitamin D together. Okay? This is your practical tips.
Yes.
Practical tips. Denosumab in the cancer patient with bone metastasis. Okay? Denosumab. It's just preference only. Preference. But as a GP, your practice will be with the bisphosphonate. Raloxifene. Extra informations. Risk of non-vertebral fracture yet not been shown to reduce. Worsen menopausal symptoms. Raloxifene. Worsen menopausal symptom. So it is important message, is not it? Because we are using the medicine for the postmenopausal lady. So for this reason, these are not actually the first drug of choice. Okay. Strontium, dual action bone agent. Already we talked about cardiovascular hazard is there. Uh, Romosozumab, it is the latest drug added in the textbook now, inhibits sclerostin. Just to tell you the name, doctor, don't be busy with such, only busy with the bisphosphonate and bisphosphonate. It is for you.
Yes.
The next one, Dr. Huma, will you feel better to read again?
Yes, sir.
Please.
What is the minimum steroid intake a patient should be taking before they are offered osteoporosis prophylaxis?
Choose the answer.
So
D.
D, equivalent to prednisolone
Possibly we
7.5.
already settled the issue before, right?
Yes,
In
sir.
discussion. So that is a repetition. Osteoporosis drug treatment for the steroid. It is not steroid. General already discussed. Irrespective of BMD, we will start the treatment in the vertebral fracture. Right. In general is nice. Now the corticosteroid use already discussed. It is just to show you, to give you them in the memory. And now regarding the steroid use, because we need to use steroid for many patients. For example, doctor, can you tell for which patient we are using a relatively longer time steroid?
Sir, bronchial asthma.
One. Usually bronchial asthma in advanced stage, oral tablet. But high dose steroid sometime in the middle category patient we are using. So bronchial asthma, one by one answer, right? Any other?
For Crohn's disease,
Which doctor?
for Crohn's disease.
Crohn's disease, maybe. Then why not
Inflammatory.
rheumatologic disease? Rheumatologic disease. SLE, rheumatoid
SLE,
arthritis.
SLE.
Yes,
Okay.
yes.
That means almost all chronic immunologic disease, even the skin conditions, pemphigus,
Mm,
pemphigoid, yeah, we discussed before. Polymyalgia rheumatica, it needs long-term steroid.
mm,
Asthma, rather a common disease. Asthma, thank you, Dr. Nawaz, as you said, asthma is a very common disease. And patients not that, according to the doctor advice, they're getting the steroid from the medicine shop and taking for the long time. They are developing Cushing syndrome. In the Cushing syndrome, patient may have the osteoporosis. So in those cases, in any background, we have to treat the primary disease as well as the osteoporosis susceptible conditions. So means the susceptible patient. So if the T score is less than 1.5, so repetition of the DEXA after 1, 2, or 3 years. If it is a less than 1.5, offer bone protection. That means treatment is indicated. Okay, doctor?
Yes, sir.
Now, I am asking anyone to explain the word offer. What is the meaning of offer bone protection? Why they have used the word offer here?
Sir, when it is not recommended, then we say it's they are offering,
No, it is
or
not. It is
opposite, sir.
not that not recommended. It is recommended, but
It is recommended, yes, sir. And in
it
case
is
of consider,
recommended.
it is not.
Yes, consider. That means
It
you
is
may
not
give
recommended.
or may not give.
Yes,
It
sir.
it it, it will not be mistake. It will not be mistake if you explain the patient about the medicine and patient denied. What will you do? But your job is to explain. This is the offer. We have to say that benefit is there, but if it is less than minus 2.5, we have to say that it is very, very important to take. In this way,
Sir,
this is one of the communication issues. Offer or consider or consider. Consider. If patient does not actually agree to take, okay, in the later time, we will try our best to consider. They start the medicine. For this reason, in this word needs explanation. Somewhere you can see that offer, somewhere you can see consider, somewhere you can see start. Start means this is the day to start the medicine. Okay. And equivalent prednisolone 10 milligram or more. This is there explain it. So not only prednisolone, you have to remember the doctor, possibly you know about the equivalent dose of the prednisolone. We discussed in our therapeutics class. Did we talk on therapeutics? Sorry, doctor. Pharmacotherapeutics. Did we discuss?
No, sir. I don't.
No.
No,
I
sir.
have not taken that class.
Oh,
No, sir.
you might be absent, doctor, and you're telling that we didn't take. You got the record definitely. You got the record. So there are few drugs where equivalent dose we must know. Traditionally, in throughout the world, in any exam, this is the steroid. Suppose 1 milligram is how much equivalent to other. So try to remember it. So I am also now for my plan searching the equivalent dose of many other drugs. It is my job now. I am just searching. If you know about, you can share with me so that we can discuss in a special class any other day. So one is the steroid, another is antipsychotic drug. You can search in the BNF, British National Formulary. You can see there antipsychotic drug. So similarly, if possible to know about the antihypertensive drug, we have to switch from this drug to another drug for some time. For this reason, equivalent drug we must know about. So here they have, so you see how much tricky in the previous answer. Maybe you see, sorry, I'm just came back. Equivalent prednisolone 10 milligram, equivalent prednisolone 7. Why they are using the word equivalent? Because the doctor didn't prescribe prednisolone. You prescribe dexamethasone. So dexamethasone also can cause osteoporosis, but which milligram? For this reason, suppose 7.5 milligram equivalent dexamethasone more than 3 months, also indication for the bone protection therapy. Okay. Glucocorticoid induced. It is just text. I copied, so I am not repeating. Now another patient. So thank you, Dr. Huma. Who other doctor colleague feel better to read it? Doctor
Sir, I'll read
Me?
it.
Dr. Rita. Okay, sorry.
Yes.
Dr. Mona. Oh, sorry, Dr. Mona. Can we give chance to Dr. Mona? She is a little late today. Doctor.
79-year-old woman is diagnosed with having osteoporosis after sustained Colles fracture. Which one of the following medication is the most likely to have contribute to her osteoporosis?
Sir, it is lansoprazole.
Yes, B, PPI.
PPI, yes.
So all of you are in the same boat like me. I am
Yes.
always in many years, every day, talking against PPI. Okay, I told you
Some
PPI means PPI causing more hazards, especially used for the long time. Yes, doctor, someone
Sir,
asking.
on average, how long would a patient have to be on a PPI before they're at risk of
It's
osteoporosis?
sorry to say, specifically not known that how many years or months, but it is said long-term use. Might be in some text we can find how long. Maybe study telling few years. But how long means don't think it is only months like peptic ulcer treatment. Okay.
Okay.
And we have to be aware of this. This your question is very relevant and important because we are using the PPI 1 month or 1 or 2 months at best for the peptic ulcer disease, not more than that. After the 1 month, if still patient have the dyspepsia, this is the indication for the H. pylori test or the endoscopy rather. What does it mean? In general, peptic ulcer disease will be healed by minimum 1 month or 1.5 month treatment by the PPI.
Yes.
If there is nothing wrong additional, for example, if underlying H. pylori infections, so PPI may not work well. If there is stomach cancer, PPI may not work well. So what is the next action? After 1 month or 1.5 month, go for the evaluation, H. pylori and the endoscopy.
Endoscopy.
Yes. But H. pylori actually to be tested in the earlier also nowadays according to the recommendations. But go for the endoscopy. So PPI, actually there is no indication to use the PPI for years together. But we are prescribing and patients are getting. And this is the hazards. Many hazards. Already you understand the osteoporosis, one of the hazards for by the PPI. And it PPI can cause renal damage also. It can cause interstitial nephritis. So many
Yeah.
things, many things, many things. I have listed already. I have shown in your class before. It's my personal collection. The just to blame the PPI, because nowadays in the PPI topics, the world medical scientists are telling de-prescribe PPI. De-prescribe. What does it mean, doctor? De-prescribe means
Any
stop.
dis-
Stop.
yes.
Stop means suppose it is not newly started 1 or 2 week, because most of the patients getting the PPI for the long time without clear indication and causing the harm, CKD and other. This is observation nowadays. I have collected a case history also from some country. One of my colleagues sent to me. They are also advising the word, the de-prescription. It is not here. Many years before I heard it. De-prescription. Try to stop the PPI if patient have the symptom, even the subjective symptom. Offer H2 blocker or antacid solution SOS. And if you suspect something wrong inside, rather not to advise for the long time PPI, rather advise for the endoscopic evaluation. Okay. Thank you. So again, to remind you that causes of the osteoporosis, GI disease, rheumatologic disease, others, and the last one is the long-term PPI. So Dr. Huma,
Yes, sir.
can we request you to search this duration and share in our group, doctor?
Yes, sir.
Definitely, it will be very good job. If possible, I will, but I'm just humbly requesting you. You search this.
Sure,
If you
sir.
have any reference specific good authentic. How long after PPI use patient may develop osteoporosis? Okay.
Right, sir. I'll try to do that.
Other than the PPI, already this one, letrozole for the treatment for sterility, right? Or even PCOS, maybe it is used also in the obstetric practice. Okay. Duration, actually, I couldn't find anywhere, sorry to say, for this reason. You have to search it. And how PPI, it is interesting as PPI is the #1 sold medicine in the world. Each and every country, doctor, even I have seen in my country data, pharmaceuticals doing the maximum business with the PPI, keeping the patients actually crippled, sorry to say. So how it causes this bone issue? Proposed means still not confident that reducing stomach acid can impair calcium absorption. So leading to secondary hyperparathyroidism. So hyperparathyroidism causes bone resorption. One of the mechanism pathogenesis, PPI causing this. So other causes of the osteoporosis we discussed before. Cause of osteoporosis, risk factors, premature menopause, chronic kidney disease, summarized in different way. Now investigations already I have shown to you. This is a book knowledge. This is the collection from that our learning materials. Okay. And one important message is mimic of osteoporosis, osteomalacia and the myeloma, multiple myeloma. That means what is the differential diagnosis of osteoporosis? Osteomalacia, multiple myeloma. So we can, if we cannot exclude clinically, we can exclude by investigations. So in the osteomalacia, you can go for the vitamin D level or other level. In the myeloma, you know, the test of multiple myeloma, plasma cell, right? The bone marrow study, the Benz-Jones protein, other thing, paraprotein, like this. Okay. And a repetition, doctor, only. Just it is for myself. I put it the list. That is a book list, and here many other new thing you may get it. Hormonal study, but in general, the what minimum test I told you that according to the cause I will plan the investigation. But in general, irrespective of many causes, the first thing we have to advise in our initial investigation plan. What are those? Full blood count, CRP, urea electrolyte, liver function test, bone profile, thyroid function test. So what organs actually we are checking minimum here? Kidney, liver,
Yes, sir.
kidney,
Liver.
liver, and the thyroid.
Right.
Because these are more relevant, commonly associated issues for the osteoporotic case. In addition, if you suspect any other endocrine disease, for example, hypogonadism, then go for the sex hormones. Fine. Still, we have few minutes time. Maybe we can go through one other patient. Yes, Dr. Azra. Dr. Azra,
Yes, sir.
please.
A 71-year-old woman who has recently been diagnosed as having osteoporosis is started on a combined calcium and vitamin D supplement. She asked about possible side effects. Which one of the following has been linked to the use of calcium supplement?
So they are asking not for the bisphosphonate hazard, rather asking about
Yes.
the calcium supplementation. I already stressed to add calcium and vitamin. Now I become worried that they are asking about the
Sir, it's
calcium
myocardial
A.
infarction.
A. Myocardial infarction.
Suppose if it is the answer, what will be your decision? Will you not give?
Sir, we have to see the normal limits and we can carry
Yes,
on.
yes. It is important. Osteoporosis, bisphosphonate, calcium supplementation, South Asian patients, vitamin D deficiency, all are interrelated. This question doesn't mean that I will not give. Rather, I will give, but I need to keep the patient under monitoring with the calcium level. Okay. So we will not allow the calcium level to be much high because it can increase the coronary artery disease, myocardial infarction. Okay. So excess calcium intake We have to prevent, but we will continue in this appropriate therapeutic level. Okay, including the vitamin D. So in the South Asian, vitamin D, vitamin D. Otherwise, calcium may not be absorbed from the GI tract. Okay. So with the vitamin D issue, doctor, possibly we discussed in our food nutrition classes. So you can review there how vitamin D started. And we are at the end near about and how to read the osteoporosis. It is already, you have seen those who are registered colleague, that your learning materials are almost designed in this way. The all osteoporosis scenarios are accumulated together here of different angles of scenarios and other things. If you go through these things, almost 90% will be covered, we believe. So
Inshallah.
our classes today will guide you and help you too much to go through all the details from there. Hopefully it will be useful, doctor. Still, if you have any query, you can raise now, doctor. Few seconds. Anyone? No more possibly. And I'd like to thank you very much. Thank you very
so
much
much, sir.
for your
Thank you so much.
participation today.